All right. Hello, everyone, and welcome to this week's Department of Medicine Grand Rounds. I am very excited to introduce this week's speaker, Dr. Matthew Altman, a rising associate professor in the Division of Allergy and Infectious Diseases and the head of the Allergy section at the University of Washington. Dr. Altman completed his medical schooling at Harvard and residency in internal medicine at Brigham and Women's Hospital in Boston before moving here to Seattle for fellowship in allergy and immunology at the University of Washington, where he stayed on as faculty, thankfully. In his time here, he has had an impactful and productive role in research as an associate scientist at the Benaroya Research Institute in the Systems Immunology Division. His work leverages his background in bioinformatics and systems biology to elucidate the complex mechanisms in asthma and other allergic and immunologic diseases using whole genome transcriptional profiling, network analysis, and multi-omics approaches to better improve our understanding of these diseases and develop new therapeutics and diagnostics. Dr. Altman, we are so grateful for your time and sharing your knowledge with us today. And as always, to the audience, feel free to leave questions or comments in the chat. We'll be watching that periodically throughout the talk, but also we'll conclude today's session with a brief question and answer session, as you are aware, using your responses. So thank you for being with us, and feel free to get started.
Yeah, well, thanks, Johnny, for that introduction, and really appreciate it. And thanks. Looks like we've got a pretty good crowd here, so that's always great to see. Yeah, feel free, I would say, to interject. I guess I think people probably can't speak, but just write in a comment. I think I can see it. I'm on two screens, and I don't mind taking questions as we go. So you can see the title of my talk there. I'm going to talk about the area that I research, so biomarkers and biologics, largely in the field of asthma. Also, touch on how allergy relates to that. And yeah, let's get started. So just by way of disclosure, so I don't have any financial conflicts of interest with industry. My funding is almost entirely through the NIH, through NIAID. I work in a variety of asthma cohorts, and then I also have some funding from our national foundation, the Quad AI. And I'll talk a little bit at the end, about some of my specific research, but kind of give a broader overview first. So what I hope to do here is review, what are the key immunologic pathways driving asthma. Asthma is very much an immunologic disease, as I will hopefully convince you. I'm going to talk about asthma phenotypes and this concept that I'm sure some in the audience have heard of endotypes. That's actually kind of been coined first from the asthma field and used, I know, in a lot of fields now. And talk about biomarkers and how that's influenced current and very current and future novel therapies in the field. So I guess just to point this out, since I do this from the research end too, I think in science and in medical school and what have you, we often think about the science as sort of a linear process. We learn something new, we're at a new level, we got a new drug, all is well. But, it's not really that. So, and this is exemplified in any field, but certainly in asthma, and I'll show you some examples of this, where we learned something, we realized a mistake we made, there's ups and downs throughout the scientific method of how we understand the disease. And that's been very true in asthma. So anyway, let's launch into it. So first off, it's important to remember what asthma is. I think we all think we know what it is. But one thing I think is often forgotten is that really asthma is a syndrome. It's not a disease. It's not a single thing. It's a syndrome that we can kind of, pick up on phenotypically, clinically. What we typically define it as, or traditionally define it as, is the combination of inflammation in the lower airways with reversible bronchoconstriction, right? So this is, the bronchoconstriction obviously is what is sort of acutely exacerbated in an asthma attack. Inflammation is more of a chronic process there that, leads to remodeling of the lung over time. But those are the two things we see. But, a lot of different insults can do this to the lung. So to that point, asthma really encompasses many different diseases, I would argue, with different etiologies, different pathophysiologies. Yeah, sort of same thing here, several phenotypes, but different triggers, different inflammatory parameters, and underlying this are a lot of different environmental and genetic factors. So, well, we'll see that. So with this is this concept of phenotypes and endotypes. So this is the Webster definition. You don't necessarily need to read this, but we all know what a phenotype is, right? It's sort of what we see in clinical practice in hospital or in a clinical outpatient setting. And so in the context of asthma, it's okay, do you have reduced pulmonary function? Do you have normal pulmonary function at baseline? Do you have a lot of exacerbations? Do you not? Do you have remodeling of the airway? The things we measure in the clinic, basically, or by history. Whereas the idea of an endotype, and again, this was coined a while ago now, 15 plus years, was that, well, there are specific molecular pathways that ideally underlie a phenotype. That's not always the case. Sometimes there's crosstalk between what's going on molecularly and what we see on the surface, but understanding that molecular pathway becomes critical to really advancing, treatment options. So why do we care about the molecular standpoint? I mean, I think a lot of us are on a day-to-day basis are more thinking about the clinical phenotype. Well, the reason, as I've already alluded to, is, it gives you specific and targeted treatments. And as we all learn about more biologics and more, molecule-directed therapies, that's critical. And that becomes a major unmet need in asthma is having effective therapies for different people. There's no really one size fits all except steroids, which really fit no one that well. This is critical for identifying those people and for doing, effective research as to, identifying new therapeutics. If you just study things in all people with asthma, you're going to come up empty-handed. So anyway, what is asthma from a molecular standpoint? Well, as I said at the start, it's an immunologic disease. Most of us don't think about the immune system on a day-to-day basis, but it underlies a lot of diseases, and it certainly underlies asthma. And, this has been known for well over 100 years through this recognition that in kids, but then evolving into adulthood, you generally see asthma occur in people who have allergies. So people who have either atopic dermatitis, eczema, who have allergic rhinitis, hay fever, grass allergy, and the like, those are the people who ultimately tend to develop asthma in what was coined long ago as the atopic triad, atopic dermatitis, allergic rhinitis, and asthma. This was really first shown in good human studies in the 90s. This is an older New England Journal paper where basically in looking at BAL cells from the lung, we see elevated levels in T cells of what ultimately we've come to recognize as type 2 cytokines. So things like IL-4, IL-5, IL-3, IL-13 became an important finding a number of years later. And that this is generally elevated in people who have asthma versus healthy controls. But, as with any biology, there's overlap here. Not all people with asthma have extremely high levels of these, and, some healthy controls do have elevation. So this coined the idea of asthma being a Th2 disease. And, as to my first diagram of the ups and downs, this was a critical breakthrough, right? Suddenly it gave us a pathophysiology of a disease where we could ultimately, target, right? So treat allergies, treat type 2 inflammation, you should treat asthma. But it took a number of years to recognize that this is not all of asthma. So anyway, that's kind of projecting ahead to where I'm going to go. But this gave us a reductionist model of asthma that we still, very much use, where the concept is, you develop allergic sensitization at the level of the skin or the upper airway or the lower airway. Allergen exposure drives production of type 2 cytokines, again, IL-4, IL-5, IL-13, which has a variety of pleiotropic effects on the airway. It recruits inflammatory cells like eosinophils that leads to B cell production of IgE immunoglobulin, which is, what ultimately reacts to allergen. It leads to effects of hypertrophy of the smooth muscle and bronchoconstriction and so forth. So, all these things we could understand in mouse or human models of, what's driving the inflammation and the bronchoconstriction of asthma. And indeed, this recognition is what gave us our first biomarker and our first targeted therapeutic, which was quite simply allergic inflammation. So it was hypothesized that if you clear IgE from the system, you're going to improve asthma. So in 2003, Omalizumab was the first human or humanized monoclonal antibody against anti-IgE. Trialed in asthma, effective, and we've had this for quite a while. So I don't want to get too much into the details, but basically, as I say, it's a monoclonal antibody directed against the IgE molecule, specifically the constant domain. It acts to decrease free serum IgE, and along with that, decreases expression of the IgE receptor responsible for sort of the allergic process on allergic cells, and it decreases circulating IL-13. So that's great. As I said, it was approved in 2003. You can think about it in your patients, whether they be pediatric or adult. It's used in moderate or severe asthma, and specifically, to use this, people need to show evidence of an allergic phenotype endotype. They have to have an elevated IgE, and they have to have a positive test to a perennial allergen, so something like dust mite or cockroach or mold. So this is sort of bread and butter in our allergy clinic. We test people for these things. We determine they're allergic, they have bad asthma. We put them on a drug like this. It's pretty effective. Again, not to get too far into the weeds, but basically it decreases exacerbations by up to half. It decreases hospitalizations. It decreases need for inhaled and systemic steroids, and it improves quality of life. And in terms of knowing who's going to respond, well, as I said, you have to have allergies, but beyond that, it didn't get us that far. We don't have great biomarkers. So we use a positive IgE as a marker to treat somebody, but a little bit counterintuitive, the level of IgE or the level of other inflammatory markers like blood eosinophils or fractional exhaled nitric oxide, which you can measure, through a quick test, don't actually show, and this has been shown in many, many analyses, don't actually predict, how well you'll respond to this drug. So we have some people who respond beautifully, some people who don't respond at all, even within that allergic phenotype. And that became critical to this step back of saying, well, not all asthma is type 2, not all asthma is allergic. And this is some really beautiful work over a decade ago from Prescott Woodruff and UCSF. This is one of those landmark papers in our field, where in effect he took a bunch of people with asthma as well as healthy controls, and he looked at the gene expression signature in their bronchial epithelium. And he specifically looked at how they respond to the type 2 cytokine IL-13. And what you can see here in this clustered heat map is that there are a subset of people with asthma who show very high expression of this gene signature in their epithelium. But interspersed with healthy individuals, there are a bunch of individuals in asthma labeled with the blue A here who don't. So even though they have allergies, they have asthma, by all means, you would say they should have allergic asthma, they should respond to Xolair, Omalizumab, they lack this signature in the lungs. So this is the idea of having to actually look at a molecular signature in individuals. What was curious here was he found these two distinct sort of presence or absence of this inflammatory pattern. Along with that, he showed differences in, type 2 cytokines, eosinophils in the airway, but you can't tell these people apart clinically. They're basically, I think I show it here, they're not clinically differentiated by, history, spirometry. You can histologically, so, if you can see higher, more subepithelial fibrosis, more mucus, but there's no great, clinical assay here or clinical, to tell them apart. So this, was this step back of, all right, so how are we going to actually define these individuals and how is this going to help us know who to treat with, one drug or another? And this began the search for other non-Th2 endotypes of asthma. So again, the idea of Th2 asthma is you're allergic, you produce IgE, you have high IL-4, 5, 13, all the rest. But what we've learned, and I'll give you the history of this in a moment, is there are other individuals who have some shared features, but they're not really allergic, or they may be allergic, but that's not what's driving their disease. And the most critical endotype we've identified is this eosinophilic asthma. So people who don't have sort of canonical allergic inflammation, but they still have a lot of eosinophils in the blood and in the lungs. And here we don't fully understand the trigger of disease. The idea that maybe pollutants, microbes, microbiome in the lung, or other such environmental, exposures lead to this, but ultimately it leads to, some of the same cytokines, IL-5 production, IL-13, eosinophil inflammation in the lung, but they don't respond to certainly a T2-directed therapy or an IgE-directed therapy, let's say. So this actually sort of broadened the umbrella to say not all asthma is allergic, and we're going to kind of call these each T2, type 2 inflammation, but through different mechanisms. What was sort of identified as part of this understanding of eosinophilic asthma was the idea that anybody with asthma can have eosinophils, but those with severe disease, eosinophils are a poor prognostic marker. In this case, Sally Wenzel showed that elevated eosinophils in the lung basically associate with a higher risk of history of intubation, and certainly also with mortality. So in severe asthma, it's a bad prognostic. And with this notion, this was actually sort of in the early 2000s as well, the thought was, all right, well, if eosinophils actually underlie allergic and non-allergic asthma, let's just knock out eosinophils and all asthma should be cured. So that was the naive, in retrospect, idea. So people understood the lineage, the development of eosinophils. IL-5 basically was identified as the crucial cytokine necessary for eosinophil maturation and activation. And so the idea was target IL-5, deplete eosinophils and cure asthma. That was tried. That was tried for many years. There were 4 studies between 2000 and 2007 treating asthma with monoclonal antibodies directed against IL-5, all of which were negative studies. This is actually before my time, but as I understand, the drug companies basically were going to abandon this approach, if not for, again, this sort of recognition that endotyping your patients is critical to a clinical trial. So these are some of my mentors, wrote review articles or opinion articles asking, so is this whole 10-year, research into eosinophils and asthma led us nowhere? The answer was no. Fortunately, people then conducted studies looking at individuals only with eosinophilic asthma. So basically those individuals that I mentioned earlier, severe disease, high eosinophils in the blood and lungs. And with that came multiple New England Journal and then a Lancet paper showing in phase 2 and then phase 3 studies that if you target this drug to people who have only these clear markers of eosinophilic inflammation, you get quite effective. So this was our 2012 called the DREAM study in the Lancet. It showed that at various doses of mepolizumab, which is this monoclonal directed against anti-IL-5, you can markedly reduce exacerbations over time in people who have high sputum eosinophils, high peripheral eosinophils, or high fractional exhaled nitric oxide, which is a quasi marker of eosinophilic inflammation. So again, this is all history at this point, but imparting the importance of understanding the molecular pathway of the disease you're trying to treat and how it varies individual to individual. In clinical practice, this is now really key. We know basically there's a linear relationship between how many eosinophils you have, how bad your disease is, and how well you respond to this therapeutic. So this is just a review article, or not a review, but a sort of meta-analysis looking at the level of your eosinophils and how that relates to your risk of severe exacerbations. So the greater your eosinophils, the greater your risk. And this is just like what Sally Wenzel showed in 1999. And then from a further analysis of that same DREAM study and its follow-up called MENSA, they basically projected out, that the higher your this is the dotted line is placebo, the solid line is treatment. So basically, the higher your eosinophils, the worse your disease is at baseline, and the greater is your response to one of these drugs. From this, they actually extrapolated down that you could use this drug in anybody with eosinophils of 150 or above in the blood, which isn't that high, to be perfectly honest. But there's no doubt, and we see this every day in clinical practice, that the greater your eosinophils, the greater response you're going to have. And people who are down here at the sort of border maybe are not actually great candidates for a drug like this. So I guess, take home is measure eosinophils in your asthmatic patients, and if they're high, even if they don't show up as red and as a critical value, if they're 300, 400, 500, the cutoff is at 500. Certainly 500 and above, send them to us, send them to one of the pulmonology groups that's, treating with these drugs, and get them on this therapy. So there's been a rapid expansion, as is often the case with a successful biologic. So there are now actually 3 different therapies on the market that target the IL-5 pathway. Omalizumab, which was the first, which is an IgG directly against the IL-5 cytokine. Reslizumab, which is very much the same, but it's IV instead of subcutaneous. And then one that's targeted against the IL-5 receptor. There haven't been any head-to-head studies. One drug company will tell you one is better than the rest, but they're all look to be about the same is the reality. Some people may tolerate one or the other better, but we have all of these 3 as options for people with elevated eosinophils and asthma. So again, a little like I showed for Omalizumab, just to kind of drive home that point. They all have slightly different indications. I think I have a table of that coming up. But in terms of their effect, on average in the population studied, so again, eosinophil levels of either 150 and above or 300 and above, you see a decrease in exacerbations by about half, a decrease in systemic steroid use that's quite marked, decreased hospitalizations, improved quality of life. One thing that's notable is none of these really have a major correction of pulmonary function. That has not been observed. What I'll tell you is we see these group level statistics and we say, all right, that seems pretty good, a decrease by half, we'll take it. The reality is these studies don't do a good job defining the heterogeneity of response. There are people who respond beautifully, who have, 4+ exacerbations a year and go to effectively 0. And, then there are some people who have a fairly marginal response. And, again, that data is not always easy to come by, but it's worth knowing that that's the case. So we're still not there in terms of personalized medicine. There's still some trial and error to this. So as I alluded to here, we actually do have a very good predictor of efficacy. If you send me somebody with an eosinophil count of 1,000 and bad asthma, I know they're going to respond beautifully to this. If you send me somebody with an eosinophil count of 300, I'm going to try it, but how effective it is to be determined. Same with more frequent exacerbations. That's a good clinical marker. Somebody who's in the emergency room, 5-6 times a year is with high eosinophils is likely to respond to this. So anyway, we've talked about, allergic, we've talked about eosinophilic. So what else is there and what's been the progress just in the last couple of years and even in the last couple of weeks is what I'll talk to you about next. We talked about those pathways of inflammation in the lung. So we have Omalizumab targeting IgE, which, triggers allergic responses. We have these three drugs targeting IL-5, depleting eosinophils. But the other cytokines I keep talking about here are IL-4 and IL-13, which really have multiple effects. But one of them is on smooth muscle hypertrophy. One of them is actually on the upstream generation or class switching of B cells to IgE production. So for the last several years, there's been a lot of interest in targeting IL-4 and IL-13, which may work across eosinophilic and allergic. It may work slightly different. We never quite know how to predict how these will work, but regardless, it seemed an easy enough target. So several therapies went after IL-4 and IL-13. One of the nice things about IL-4 and IL-13 is that actually they share a common receptor, or at least a receptor component. The IL-4 receptor alpha is common to both the IL-4 receptor itself and the IL-13 receptor. So the drug that actually proved effective in this field, or in this area, was one that targeted the receptor. So dupilumab is a monoclonal antibody against the IL-4 receptor and effectively can block signaling through both IL-4 and IL-13. Interestingly, there was a study of an IL-13 directed monoclonal. I'm not going to show it here, but that actually failed to show efficacy. So something about the dual effect of these pathways probably is what's relevant. So just a couple of years ago, in New England Journal, we got our first phase 3 study looking at dupilumab as a monoclonal against, again, IL-4 and IL-13. This was ages 12 and above, moderate to severe asthma. And interestingly here, they didn't actually stratify. They took sort of all comers with severe asthma and were, in some ways, a little bit lucky to see a decrease. So basically, same idea, decrease in exacerbation rate by about a half. They did 2 different doses of the drug, but basically they were the same. And here I just pointed out they showed a slight improvement in pulmonary function. How clinically important this is, I think, is to be determined, and how long-standing this is. But a modest improvement in FEV1 by a little over 100 milliliters. So they did look back, as I said, they kind of took asthma all comers, but they looked back at the importance of, for example, eosinophils or FeNO. And indeed, as you would expect, it was those individuals who had higher eosinophil counts, higher FeNO, who had the greater response. And in fact, those without eosinophilic inflammation or with a normal FeNO didn't really show response to the drug. The one advancement I sort of said early on, FeNO is not the same as eosinophilic inflammation. And you can have one or the other or both. So definitely one advancement that came here was the identification of individuals with a high fractional exhaled nitric oxide, which again is a quick breath test in an office, takes a couple seconds. But normal eosinophils are still probably good responders to this drug. So it gives us, it's another thing in the armamentarium where we can, look at a biomarker and potentially have a good therapy for somebody who doesn't fit for our previous biologics. And I'll also just say, for some of those people who have more marginal eosinophils, we sometimes see a good response to this if they don't respond to an IL-5 directed therapy. So I'll pause for a second and just tell you where we are before I tell you, where we're going. Because as I say, there's been some advancements even just in the last couple of weeks. So basically we have different endotypes or quasi-endotypes. So the allergic asthma, which is the biomarker we use there is elevated immunoglobulin E and allergic sensitizations. And, there, the targeted treatment we have is anti-IgE, or I didn't go into this, but the more historical approach is just immunotherapy, which has mixed results for treating asthma. That's where we desensitize people to the things they're allergic to. The next endotype is eosinophilic asthma, and there's some overlap, obviously, but these are people with particularly high blood eosinophils. And there we think about IL-5 or IL-5 receptor alpha targeted therapies, or, and again, this is an overlap, high FeNO, where we think about dupilumab targeting IL-4, IL-13 pathways. For the sake of time and just sort of for the audience, I didn't mention this other one, but this is one we've known about for a few decades, or for several decades, that you'll probably remember from med school, if nowhere else. This is previously called Samter's triad. It's people who have this interesting allergic reaction to NSAIDs, right? So if you have somebody with, significant asthma, sinus disease, and they have allergies to aspirin and ibuprofen and whatnot, they have a very distinct leukotriene-mediated disease, and they respond to leukotriene modifiers and paradoxically aspirin desensitization. They probably also respond to anti-IL-5, but that hasn't been studied in a ton of detail. Again, this is more for sort of the people who are prescribing this, but these are the 5 drugs on the market, sort of what they do, some details about their age range and dosing and whatnot. But suffice it to say, in adults, we have, each of these options, and we use them all in our clinic. So again, before I move to the future, I do want to, I added this into a previous talk. I think it's important. I perhaps should say this at the outset. Everything I'm talking about, right, is people with, severe disease or at least moderate disease, right? I'm biased because that's pretty much all I see. I don't really see much in the way of mild asthma anymore. Nobody refers it to me. But remember your stepwise therapy. For people with mild asthma, we're still using simple bronchodilators, inhaled corticosteroids. Some of you may be aware the new recommendation for people with mild asthma is actually use a as-needed combination ICS plus a short-acting bronchodilator. The problem is that this is hard to do practically because insurance doesn't pay for it. But regardless, so for mild and moderate, definitely you're still doing your stepwise albuterol, Flovent, what have you. But really, I mean, as soon as they're having exacerbations, need for systemic steroids, hospitalizations, I have a pretty low threshold to think about a biologic, right? I mean, steroids are bad, is the short, the short of it. And if I can save people systemic steroid doses throughout the course of a year, I definitely think it's worthwhile. So, there's an index for referral or not, somewhere in there, but, think about it in people who are struggling. All right, so where are we going, or where have we gone just recently? So I talked to you, I think this is perhaps the same slide I showed earlier. We have T2 high asthma, we have non-T2 asthma, we have targets, as I just summarized. A lot more has been discovered. So first off, we know that the airway epithelium is really critical to the pathogenesis of asthma. This was, all mouse models, then human models. But the airway epithelium, when it's damaged in some way or insulted in some way, it produces a variety of pro-inflammatory cytokines, the ones that are becoming increasingly, I don't know, I'm sure this is being taught now in medical school immunology, IL-33, IL-25, and TSLP, which are sometimes called alarmins. They sort of are part of the innate immune system, raising the alarm bell, from a viral infection or pollution or what have you. And a lot is still not understood. This is a very active area of research. Is sort of like, when exactly are these released? How are they released? How can we modify them? But suffice it to say, they become essential for propagating inflammation in asthma. So, not surprisingly, people identify them, people target them, so we can build monoclonal antibodies to these. So this was what we had to go off of until recently, a phase 2 study in the New England Journal of a monoclonal targeting TSLP. And basically what was shown here is, in this phase 2 study was a very significant reduction with tezepelumab is the name of the drug. This is annualized rate of exacerbations, which has become the primary outcome for each of these drugs. Decreasing, and what they show here, and again, we'll get into this in a bit more detail, but basically, whether you have high or low eosinophil counts, this may work. Whether you have high or low FeNO, this may work, although it certainly seems to work more in people who have higher FeNO. And this sort of summary metric of what they call the Th2 status, so sort of allergic or eosinophilic, may have efficacy. So it may have efficacy outside of the endotypes we've already defined, is the idea. Just published earlier this month was the phase 3 study of that drug. Now New England Journal just gives you these graphical abstracts, so I can just give you the sort of pretty summary overview. But 1,000 patients, adults and adolescents with exacerbation-prone asthma, treated with this drug versus placebo, and they saw about a little over a 50% decline in the annualized rate of exacerbation. So pretty good, pretty similar to what we've seen in other drugs. And generally quite safe. So here then, is one of the figures from the manuscript, much like what I showed you a moment ago with the anti-IL-4 receptor drug, stratifying patients now by these biomarkers we've developed. So whether you're allergic at baseline, positive or negative, it's a very similar response. Whether you have eosinophils or not, certainly there's a trend here, right? So it's the people with higher eosinophils, no doubt, who have the greater response, the people with higher FeNO who have the greater response. So, we're making progress. Again, there's going to be an area for use of this drug beyond what we currently have. We don't have any head-to-head studies, of course, but, there's an argument to be made that people lacking these inflammatory markers may respond to this drug. So that'll be, I'm sure, that's under FDA review now. I'm sure we'll have it in the not too distant future. We've been involved in a number of research studies with it. It's an easy to administer and, safe drug. So, we know T2, we know eosinophilic asthma. The problem really, and what everybody's trying to get at, is there's still this large group of people lacking type 2 inflammation, lacking allergies, lacking eosinophilic inflammation. And truth be told, we still don't know a lot about what's going on here or how to treat them. The people who manufacture this drug are going to tell you, oh, this drug is great for it, but that remains to be seen. It's a very heterogeneous group of people who have non-type 2 inflammation. And I'll show you now, I'll kind of transition from the clinical into the research side of my talk of how we're trying to figure this out. What are some of the leading candidates? Where might we be in the next 5-10 years for treating this? Non-insignificant. This is certainly less than half of asthma, but it's not rare. And we actually see it more in adults than kids, right? So adult onset asthma is often more type 2. That's what this diagram is meant to indicate. We see it more in obesity. We see it more with smoking association, pollution association. We see it more in women than men. So we know sort of a lot of kind of quasi-epidemiologic features of this, but we don't really understand it molecularly yet. And so this is, again, we can take all sorts of great summary articles of, all right, how are biomarkers going to predict this? How do we get insight here? So I'll go through a few appealing ideas that are in the field and, kind of try to fit them into what we know and what we don't know. So I guess I didn't introduce this, but a lot of asthma exacerbations are triggered by respiratory viruses. I think if you think about your clinical population, you'll know this. Exacerbations happen a lot in the fall and winter when respiratory viruses are circulating. You'll see often somebody gets a cold, gets upper respiratory symptoms that leads to worsening of their asthma. So for a long time, there's been this concept of there being a problem with the antiviral response in asthma. And some early work here by Peter Wark showed that maybe, this is a kind of crude model, but if you look at epithelial cells and you infect them with rhinovirus, the most common cause of the common cold, people with asthma create less interferon. And there's less interferon to be found in the supernatants. And, there were various other studies sort of trying to build on this, saying, all right, at least some people with asthma don't mount a good interferon response to rhinovirus. So I'm not going to show you all those studies. This was actually then taken to a clinical trial. So interferon's an easy enough drug to administer. It's not the most pleasant thing to receive, but if you put it in inhaled form, it's without a lot of side effects. So there was a study of inhaled interferon versus placebo as a novel treatment for asthma. Here they were looking at basically a symptom score, and they didn't see a clinically relevant difference with treatment with interferon beta around the time of a respiratory infection. Of course, with any of these, people go back and look at subgroup analyses. So they did go back and suggested in a subpopulation there could be a difference. where you see, an improvement in this ACQ-6, with treatment versus not. But it hasn't come into prime time, of asthma, and part of it is because this is some of our work, but others too. We're sort of really diving into understanding the interferon response more. So here we looked at interferon response by gene expression and by interferon beta production in kids with asthma versus healthy controls. And we actually saw sort of a dichotomous division here that based on a clinical dichotomy of children, some actually had an excessive interferon response, whereas others had a slightly lower than normal interferon response. So it's almost as if there's a bifurcation. Some people who make too much of an interferon response, which in itself could be harmful, and some too little. So from this and a variety of other works, there's this concept that perhaps the interferon story is more one of Goldilocks. Too much is a problem, too little is a problem, and you sort of need just right. But we haven't figured that out, nor have we figured out how exactly you would then implement that in clinical practice. It's not easy to measure somebody's interferon response and use that as a biomarker. That said, work by some colleagues here, are trying to get into the genetics of this. So interferon responses are under a lot of genetic control. So could you identify those people who are, interferon responders, non-responders based on genotype? So I don't know, a possible future. But beyond looking at targeted pathways, now, and this is, as was mentioned in my background, this is kind of my field, can we use big data to start to unravel the heterogeneity of asthma? So there are a number of groups going after this. These are complicated figures to read. This is an article I reviewed and wrote an editorial for a few years ago. There's a European group called Biopred, which has large cohorts of adult asthma. And they're looking at gene expression profiles, in this case in the blood, and trying to come up with distinct clusters of individuals who have, this is a heat map showing roughly, 16,000 genes in peripheral blood, and then individuals clustered along the top. And the take home is, you see some big blocks of red, which is upregulated genes, some big blocks of blue, and you have bifurcations, right? Some individuals show one pattern versus another. In this case, the main thing they could discern out of this from a topological analysis was that there are people who have a really high neutrophilic signature. That's in effect what these genes were telling them, and some who don't. And this and other work has led to the idea of neutrophilic asthma. Is there a role there? Is there any way we can target the neutrophil? The reality is this has not led to any clinically or sort of obvious actionable drugs. I shouldn't quite say that. Nothing that's, sort of in the immediate pipeline for, a clinical therapeutic. Because how this really linked to clinical characteristics or how you treat this was a little bit unclear. Here, so this is sort of here they were looking at blood. I think the more relevant organ to be looking at is the airway. So Biopred has also done that. They've looked at bronchial biopsies, which are much harder to get. They've also looked at sputum. But again, using gene expression profiling to build clusters of individuals. Here they identified these distinct clusters, each point being an individual, and the lines basically showing the link between them. And this is a nice study, but the main thing they discovered was a rediscovery of people with high eosinophils, high exhaled nitric oxide, and high steroid use, so sort of eosinophilic asthma. So very interesting, as a way to get insight, not yet telling us, how to identify and treat these patients. Just to run through a few others, this is also Biopred, a more recent paper identifying the inflammasome as a potential mediator. So a subgroup of people with severe asthma who don't smoke, who have elevation of inflammasome pathways. We do have drugs targeting the inflammasome, so there's interest there as a potential target. this, to some extent, associated, as I was talking about before, with having higher neutrophils, so an overlap between inflammasome and neutrophilic inflammation in the lungs. So again, an idea of possibly moving that forward. Another one, this is out of the same group at UCSF. Again, basically trying to identify from larger data sets markers of inflammatory pathways. So here they targeted on IL-6 and showed basically higher plasma IL-6 associating with higher blood eosinophils, and in this case, possibly being a marker of severe disease, more in obesity, but also present in people with a normal BMI. So, again, an active target. We obviously have drugs targeting IL-6, so there's interest in moving that forward. This is some of our own work, and the point here is just to show that there's people can have different pathways of inflammation underlying their asthma, and that there are kinetics to be involved here. There are relevant kinetics here too. So basically what we did was we took a cohort of children with severe disease, and we took repeated measures from the upper airway, from the nose, when they were at their baseline, so not having a respiratory illness, not having an exacerbation, and we tracked them through respiratory illnesses. And we looked at gene expression profiling of those nasal samples and asked, what are the networks of gene responses that relate to an exacerbation? So in this case, we could identify a pathway of a viral exacerbation, which you'll note some common things I mentioned earlier. So IL-33, that epithelial-derived inflammatory mediator, but a whole lot of other stuff associated with the IL-3 pathway being upregulated in an illness that progresses to a viral exacerbation. But what do we have here? I cut some stuff down, but and then we otherwise also see pathways that are sort of common in viral and non-viral exacerbations. So this was a pathway of TGF-beta signaling, which we know is important in airway remodeling, that we saw as a sort of a common factor across a variety of exacerbations. And I'll just show you the models we built. Basically, by doing this, we could build different modules of inflammatory pathways that are activated at different time points during an illness and that either progress to an exacerbation or not. So when we saw a viral trigger leading to an exacerbation, we saw this combination of IL-33, type 2, SMAD3, TGF-beta, actually elevated interferon responses, leading to a bunch of sort of effector pathways, so to speak. So mucus hypersecretion, extracellular matrix production, and the like. Whereas we saw in these same children, if they had an exacerbation in the absence of a virus, a quite different entry point. So we saw tissue kallikrein induction, keratinization pathways in the epithelium, ultimately leading to many of the same effector pathways. So suggesting there are different triggers and different immune entry points to an exacerbation, and there may not be one. So if you target IL-33, you may block some exacerbations, but not others, even within the same person. So just adding another layer of complexity of how we ultimately treat people. We subsequently showed what are some of the triggers for this. So in particular, we showed pollution, and we've also shown genetics underpinning this, just published a week or two ago, basically showing genetic differences in the mucin genes relating to the degree of ultimate mucus hypersecretion and airway obstruction. So the take home is a lot to be derived from big data, gene expression, protein, to really understand the pathways by person and the pathways by time that drive asthma. So, that is not meant to give you a take-home. The take-home was the first half of the talk of where we are so far. But to go back to my original paradigm, overall we're making progress. But, if we trace through the history I just showed you, in the 80s, 90s, we identified Th2, allergic asthma. We then sort of identified eosinophils, but we didn't act on it properly. We ran studies that didn't target eosinophilic inflammation. So then we sort of realized in 2009-ish the importance of endotyping. this led to the emergence of the biomarkers and biologics I described, so IgE, eosinophils, FeNO, anti-IgE, anti-IL-5, anti-IL-4, anti-IL or anti-TSLP therapies. The recognition ultimately that that's not all there is to asthma, now trying to unravel this non-type 2 inflammation where we're, in the up and down phase, interferon, IL-6, kallikreins, inflammasome, neutrophils, and trying to understand how that may ultimately take us towards, what we all kind of in our field these days are calling the Holy Grail, and we have to write in the grants that I'm working on right now, of how do we, get towards a personalized management strategy. And, obviously, again, I want to point out this isn't for everybody. Mild asthma, we have good treatments for, but at the end of the day, having effective and hopefully ultimately affordable ways to manage people in a targeted fashion that prevents mortality from asthma, prevents corticosteroid requirement and the morbidity associated with that, airway remodeling is really critical. So with that, I have a little over 10 minutes, or a little under 10 minutes left. Just say thanks. Always happy to chat if you want to email me. Always happy to take referrals. We have sort of focused severe asthma clinics, both at UW and Harborview, where we can take these referrals. We're pretty busy getting them in. So if you have somebody who's urgent, just shoot me an email and we'll see what we can do. So with that, I'll conclude and we can take questions.
Yeah, thank you for that talk. And I appreciate that sort of figure at the end, which is just so demonstrative of translational research and sort of the progress towards personalized medicine involves these incremental steps as you sort of define more and more enriched endotypes and enriched for some sort of activity from these biologic agents. So just a really great reminder that it's not like an epiphany happens all at once, but it's the hard work of folks like you who are defining these subtypes. So thanks so much. One of the first questions that came in from one of our pulmonologists, I think is a tricky question to answer, but how do we get pharmaceutical companies to do those head-to-head trials when it comes to these biologic agents?
Yeah, so you may know it's a hard, if not impossible question. There was an editorial now, maybe 2 years ago, Jeff Drazen in the New England Journal, basically calling on pharmaceutical industries to do those studies to say, look, this is unfair to patients, it's unfair to doctors, it's unfair to the medical system. The problem is, to their bottom line, there's no benefit to them of showing their drug is inferior or risking that, showing their drug is inferior. There have been a lot of meta-analyses of these, and, my honest opinion is they're fairly equivalent if you just kind of look at all comers with type 2-ish inflammation, but every company has published their own review saying why theirs is slightly better. We are doing it indirectly, I will say. We are in children looking at mepolizumab and omalizumab. So anti-IL-5 and anti-IgE. I guess don't tell anybody this or they might, pull funding. But trying to get at that, it's not a head-to-head study. It's sort of looking at people who would qualify for either and how they respond. And so I don't have an answer for you. Maybe as things become generic, there's more opportunity for that. The NIH has interest in it, but doesn't have the money necessarily to do it, and you kind of need pharmaceutical to give drugs to do those. So I don't know. We're trying to do it on a small scale where we can, but it's challenging.
That's one of the negative externalities of the incentive system we use, right? So that sounds like a big challenge. Yeah. Another question here. Can you speak to some of the potential risks of long-term immune modulation, specifically in these IL-5 and IL-4 agents?
Yeah, no, it's a great question. And, certainly any immune modulating agent, you have to think about long-term risk or short-term and long-term risk. And I will remind you, I'm not paid by these companies. It's been pretty amazing to be working in this field because the current drugs we have been amazingly safe. And we have been using these drugs for quite a long time. So omalizumab since before 2000. The first trials of mepolizumab were in the early 2000s. So we have actually, decades really of data on several of them. And we're not really seeing any long-term negative consequences. I mean, fortunately, this arm of the immune system, which evolves largely to combat, we think parasites, certainly in the developed world, seems to not be very important. Even in other parts of the world, you would think, all right, so based on what I just said, you're going to see parasitosis and other things like that. That's not really been observed. And, even, you think about, again, I remember this from residency and whatnot, strongyloides, and don't treat people with steroids because you might get disseminated. Like, we haven't really seen cases like that with these drugs. So it's a pretty modest immunomodulatory effect without a lot of negative outcomes. Now, I don't expect that to be the case for everything. So anti-IL-6 absolutely has issues. It has immunosuppressive issues. So if that becomes, something we use, or targeting IL-6, I should say, not anti-IL-6, but similarly, anti-IL-33 approaches. IL-33 has a lot of other functions, including neuronal development. So there's a lot of concern there, especially if you start thinking about treating young children. So it's critical to think about these things. It's critical to monitor these things. And I will say, at least for what currently exists, fortunately, it's not a big issue.
That's awesome to hear. I have a question, which is, how has the sort of your evolving understanding in these moderate, severe cases of asthma, and as you start to define these endotypes, has that changed your way of understanding or teaching or practicing as far as the treatment of those patients who have more mild disease, but maybe still fit under these endotypes? Are you starting to conceptualize patients earlier or sort of at lower severity in terms of these endotypes? And does that change your approach to treatment at all?
I would say yes. I mean, so anybody who I see for asthma, no matter how mild they are, I try to categorize in this way or think about in this way. Even if I have no, even if they're super mild and there's no way I'd give them an expensive biologic. Because, fundamentally, I just think mechanistically, so it helps me understand what disease they really have rather than kind of giving them a syndrome. And, because even simple things like if I know they're highly allergic, I'm going to recommend, the things I didn't actually get into in this talk, but if you come work with us in our clinic or if you, go into our field are very relevant. So, allergic or, modifying environmental factors, treating allergic rhinitis, these sorts of things. So yeah, I try to teach my patients so they kind of have a sense of their disease, have a sense of their triggers, same thing, even with the baseline drugs we have, so we have inhaled steroids, but we also have, leukotriene agents, and there's a distinct role there to some extent based on, what sort of endotype I think they have. As an example, people with exercise-induced symptoms tend to respond well to the leukotriene agents. So
even if we're
one example,
even if as we employ these sort of population health strategies for treating mild asthma, like thinking about it as even as an internist in terms of these buckets may help you better understand maybe what's driving it, and then that flows well into another question which came through, which is how do we think people move between categories of severity? Is there a chance that sort of knowing this up front for these patients means if they start to get worse, you better opportunity? No,
that's a great question and a great point. That's exactly right. So that's the other thing that was in my mind. I didn't say just there. So asthma is a progressive disease. We do often, some people get better, but some people absolutely get worse. And, I see that, and they're usually referred to me after they've gone down the hill, right? So absolutely. I think ahead knowing like, all right, and I've had 20-year-old patients who I follow for several years who are doing pretty good, and then things kind of go downhill. And so knowing, hey, you've had eosinophils elevated for the last 5 years, okay, I'm going to treat you with this drug. So absolutely, asthma is not a static disease; it changes over time. So it gives you a sense of what you may have down the road. And I tell my patients that, I say, look, you're doing well now. You're fine with just this, but if things get worse, here are the options that would work for you.
Awesome. Well, thanks so much. I think that is our time. If there's any other questions, feel free to drop them. But thank you everyone for tuning in for this week's Grand Rounds, and have a great rest of your Friday. I had a question come up, but you answered it really well, which is it just seems like there's characteristics of the individual endotype, but also the exacerbation endotype, and that just seems like a challenge to tease those two apart when you're thinking about therapy. So it sounds like that's sort of the future too, is sort of teasing those two apart.
Well, that's what they're paying me the big bucks to do. So
awesome.
So we're working on. Yeah, we've got some really cool trials that we're doing to try to sort that out. But I'll come back in 5 years.
We'll have to have you back. Exactly. Excited to hear the results of those. Thanks so much.
Yeah.
Thanks, everybody.
Cool. Thanks all.